Hello everyone and welcome to this week's NDARC webinar. I'm Alice Havard, a researcher at NDARC, and it's my pleasure to be hosting today. I would like to begin by acknowledging the Bidjigal people as the traditional custodians of the land on which I'm working today at the UNSW Randwick campus. I would also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations across the country. We pay our respects to the elders past and present and extend that respect to any First Nations people joining the webinar today. Now, it's my pleasure to introduce today's speaker, Oisin Stronach. Oisin is a PhD candidate at the Burnet Institute, where his research investigates the drivers of methamphetamine-related mortality in Australia. In the webinar, Oisin will present his research on trends in methamphetamine-related deaths in Australia over a 20-year period, highlighting findings from an age period cohort interaction analysis of these deaths. As our expert panelist today, we're lucky to have Dr. Amanda Roxburgh, who is a senior research fellow at the Burnet Institute. Amanda has over 20 years of experience in the alcohol and other drugs research field and is renowned for her expertise in drug-related mortality. And she is also primary supervisor for Oisin's PhD. Oisin and Amanda will take questions from the audience after their presentation. You can log questions for them using the Q&A function at the bottom of your Zoom window. Okay, Oisin, I'll hand over to you now.
Thanks, Alice. Hi, everybody. I'm Oisin Stronach, and I'm presenting my study, which is titled A Age Period Cohort Analysis of Methamphetamine-Related Deaths in Australia from 2001 to 2020. And before I get going, I'd also like to acknowledge the traditional custodians of the land, the Aboriginal and Torres Strait Islander people of the First Nations. I express my gratitude to the Wurundjeri Woi-wurrung people of the Kulin Nation whose land I'm on today. I'd like to pay my respects to the elders past and present. This always was and always will be Aboriginal land, when I'm very grateful to live, work and play. So Australia is thought to have one of the highest rates of methamphetamine dependence in the world. And in recent years, we've seen an increase in the volume and frequency of recent seizures at Australian borders. So methamphetamine use in Australia has kind of changed since 2001, with fewer people using the powder form of it now, but there's been a rise in the use of the more potent crystalline form due to increased availability of at lower costs. And those who use crystal methamphetamine do so more frequently and do so more in more harmful usage patterns. And we've seen a rise in the number of people smoking it these days. This has become a kind of a growing health concern in Australia, with increases in methamphetamine-related hospitalizations, treatment episodes, and mortality. And the trends that we're seeing in Australia are not like isolated. These are part of broader international trends of increasing methamphetamine use and mortality. So to look into these issues, the first part of this research aimed to examine trends in methamphetamine-related deaths across a 20-year period from 2001 to 2020. So this first part of this research involved a joint point analysis, of data from the National Coronial Information System. So for those who don't know, this is a big database of all reportable deaths in Australia. And we extracted a cohort from the NCIS of all Australian deaths since 2001 involving methamphetamine or amphetamine as the underlying or contributory cause, as determined by the coroner. So we excluded cases where deaths were due to related substances like MDMA, MDA, MMDA, or dexamphetamine, or involved people under the age of 15. So we classified these deaths into four main categories, which were unintentional drug toxicity, intentional self-harm, natural causes, unintentional injuries, and assaults. And I'm now going to get into some results, but before I do, I just want to acknowledge the data that I'm presenting on today represents the lives of real people. So I'd like to extend my acknowledgement to all people with a lived and living experience of drug use and to those impacted by drug-related harms. I also want to flag that this presentation includes a little bit of discussion around suicide and assaults. So if anyone feels impacted by any of these topics or any other aspect of the presentation, please reach out to someone you trust or contact some available support services. Some of them were just mentioned in the chat as you were arriving. So in total, I found that there were 8,812 methamphetamine-related deaths since 2001, which made up 0.27% of all Australian deaths over this time frame. So the vast majority of these deaths were males. And interestingly, we found that the median age of death has increased from 29 to 42. 44% of the cases we found had a recorded history of injecting drug use. But we think this is quite a substantial underestimate, as it kind of relied on forensic evidence of injecting drug use being found at the time of death. So yeah, take that with a little bit of yeah, it may not be quite as accurate. So 72% of deaths were in metro areas, and the majority of deaths occurred in Victoria and New South Wales. However, you can see there on the little map that Western Australia had the highest mortality rates out of any state by a considerable margin. So when we break these deaths down to categories, we can see that 52% of deaths were due to drug toxicity, and most of these involve multiple drugs. And these were commonly opioids, benzos, and antidepressants. And then 21% were due to intentional self-harm, followed by unintentional injuries in 15% of deaths. And here we had 71% that were related to motor vehicle collisions. And then natural causes made up 9% of these deaths, and these were mostly due to circulatory system diseases. And then we have a small proportion that were assaults or homicides. So we then use JoinPoint, which is a software, to identify some changes in all-cause mortality rates over time. So we can see that there were 4 distinct phases of change. Phase 1 occurs from 2001 to 2006. It's categorized by a slight but significant upward trend in mortality. Phase 2 occurs from 2006 and 2009, and this we see a little small decline in overall mortality rates. Phase 3 occurs from 2009 to 2016, and this is where you can really see we saw that really significant increase in overall mortality rates. And then after this, we have phase 4, and that occurs from 2016 to 2020. And here there appears to be a slight decline in mortality rates. But we know from coronial data that there is a bit of a lag in when we receive data and when it's complete. So the 2020 data has probably risen further now since more cases were finalized. So this is the unintentional drug toxicity trends. So we saw just 2 trend change points for this one, or 3 trend change points for this one. And so the large increase you can see between 2011 and 2016 is largely being driven by a significant 4-fold rise in mixed drug toxicity. So from 2016 to 2020, there was a slight increase in mortality rates, but we saw a stabilization of opioids in these deaths. So among natural causes, there were 3 trend change points in 2007, 2010, and 2015. So the large increase from 2010 is mainly among people in their 40s and 50s dying from circulatory diseases. And when we look over the 20-year period, we saw that there was a 7.5 times rise in the rates of circulatory system diseases. And these deaths are mainly caused from ischemic heart disease, which is a trend that appears to be on an upward trajectory in Australia. Since many of you are in New South Wales today, I thought it might be interesting to see what the trends looked like up there. So as you can see, the trend's largely the same as what we saw on the national all-cause mortality rates. There were 3 trend change points in 2006, 2009, 2016. And the increase between 2009 and 2016 is bigger than what we saw nationally. And the decrease between 2016 and 2020 is smaller than what we saw nationally. So this is kind of showing that it's kind of plateaued out more recently in New South Wales. So these findings show that these methamphetamine-related deaths are quite complex. We've got a large variation over time and by cause of death. So kind of reiterates what other people have said across the years, that this like a one-size-fits-all approach won't work for methamphetamine deaths. We've got to need a series of targeted responses to effectively reach population experiencing methamphetamine harm. And we categorize the death based on the coroner's finding. And it's important to acknowledge that these deaths are more complex. They frequently involve a combination of factors like including multiple drugs and both acute and chronic cardiac conditions associated with regular methamphetamine use. And distinguishing these contributory factors from acute methamphetamine toxicity presents a significant challenge for us as researchers and for the coroners as well. So we've got natural causes were the only cause of death that continue to rise after 2016, other than drug toxicity. So now I want to show you some international trends, which are slightly different to our own experiences here in Australia. So on the right side of the screen, we have the crude mortality rates for all-cause methamphetamine-related deaths in Taiwan. So unintentional drug toxicity deaths make up a higher proportion of their deaths at 67%. And their trend suggests that methamphetamine-related deaths kind of reached a plateau between 2015 2017, which is a similar time to where we saw our peak here in Australia. But unlike Australia, they've seen a considerable drop off since then. And on the other side of the screen, we have the number of deaths for all-cause methamphetamine-related deaths over time in the US. So Hopsick and Yockey found that between 1999 to 2021, there was a 50-fold increase in methamphetamine-related deaths, which were accompanied by an increased proportion that co-involved heroin or fentanyl, peaking at like 61% in 2021. So this suggests that the increase in methamphetamine-related deaths in the US that they saw over there is largely being driven by the opioid co-use. So particularly the rise in the use of fentanyl and fentanyl-related analogs, which we haven't really seen here in Australia. And I just included this one to add a little bit more context about the situation in the US, as we see that really distinct J shape for the methamphetamine-related deaths up until the end of 2021, the slide before. But when we look at the more recent data for Centers for Disease Control and Prevention on overdose deaths for all drugs, shows that from 2022, there's been a bit of a plateau, and we see there's been a drop in the more recent years for the number of overdose deaths. Important to note, this is all drugs and just overdoses. So it's still unclear what it means for methamphetamine-related deaths. Whether that will also trend downward, but it's kind of a bit of a hope that that trend is not worsening over there. So as we kind of saw that there was something going on with the age-related trends among the methamphetamine-related deaths, we next aim to describe the age period cohort patterns for Australian methamphetamine-related mortality between 2001 and 2020. So this analysis, we use the same cohort as before, but we just include deaths from 2001 to 2020. And we used all causes apart from assaults because we had quite a bit of quite a small amount of deaths in that category. So when we look at trends in methamphetamine-related deaths, it's quite a little bit complex because we've got these three related effects that influence changes over time. We've got age effects, we have period effects, and we've got cohort effects. So age effects are changes that happen as a person gets older. For example, physical health often declines with age, increasing the likelihood of conditions such as cardiovascular disease. Period effects are changes that affect everybody at the same time. So a great example of this is the COVID-19 pandemic, which affected everybody all at once. And lastly, cohort effects are the impacts or events of social changes that affect people differently based on when they were born. So an example of this is the introduction of the internet has had different impacts on different generations, such as baby boomers and Gen Z. For baby boomers, they kind of had the internet introduced into like a bit later in their adult lives. So they may not have the same digital fluency as younger generations, whereas Gen Z grew up with digital technology kind of as a constant presence throughout their life. So generally makes them highly proficient and more comfortable navigating online platforms. So if anyone's ever really had anything to do with age period cohort analysis before, you'd know that these models encounter some limitations due to the identification problem, which stems from the linear relationship between the three variables as cohort equals period minus age. And this makes their effects hard to separate. So think of age period and cohort as three different paint colors. So you've got red, blue, and yellow, and then you've chucked it all into a bucket and you've stirred them round. And you've got that single muddy brown color at the end. And once you have that color, there's no way to tell how much red, blue, and yellow you actually had at the start. So that's the identification problem. You can see the combined effect, but not each one separately. So researchers have proposed a range of methods to resolve the identification problem. These methods tend to assume that cohort effects are independent of age and period effects. And they kind of ignore that cohort effects may vary over a person's life. And this actually doesn't align with the theoretical conceptualizations of cohort effects we see in the sociological discipline. So this study uses a new method developed by Liu and Hodges in 2020 called the age period cohort interaction analysis. So this just allows us to look at cohort effects and allows them to vary over a person's life. So APC-I can then be used to identify differences between cohorts, such as like differences between generations and differences within the same cohort over time. So this is the first time that an age period cohort analysis has been applied to methamphetamine-related deaths in Australia. And it's also the first time that an age period cohort analysis of methamphetamine-related deaths has been stratified by cause of death internationally. And it's the first time that this APC-I method has been applied to drug-related mortality more broadly. So this slide shows how I group the data. So as you can see, the age at death was grouped into 4-year age groups from 15-year-olds to 62-year-olds. And periods were also grouped into 4-year groups from 2001 to 2020. And then birth cohorts were defined as period minus age. And these cohorts were then grouped by their birth, by their generation. So I'm just going to touch on this slide briefly. I know some of the text is a little bit small, but this slide shows crude mortality rate by age and period for each of the 4 causes of death. So the more intense the color is, the higher the mortality rate. And as you can see, there are rough wedge shapes formed for each of the 4 causes that shows that the age at death is increasing and there's been an intensification of mortality as the period increases. And so this is our first indication that we may have some potential cohort effects going on here. So this graph shows age effects by cause of death. So a positive value indicates that a age group experienced a higher mortality risk compared to the global average. And I say global average, I mean the average of the whole group that we had, like the whole sample that we had, not the global average and across the world. So after adjusting for period effects, unintentional drug toxicity age effects peak between 23 and 50-year-olds. Intentional self-harm age effects peak between 19 and 46-year-olds. Intentional injuries peak between 23 and 34-year-olds, and natural causes peaked a bit later, 31 to 50-year-olds. So this graph is similar to the one before, but this shows the period effects by cause of death. So again, a positive value here indicates that the period had a higher mortality risk compared to the global average. So after adjusting for the age effects, All causes of death show significantly higher mortality risk between 2013 and 2020. The unintentional injury deaths peak between 2013 2016, while the rest kind of peaked in 2017 to 2020, so a little bit later. So this graph is cohort effects by cause of death. So positive value here indicates that a cohort experienced a higher mortality risk compared to the global average, whereas a negative value suggests that that cohort has a lower than average mortality risk. So what we saw here, we saw some negative cohort effects among baby boomers, which turned positive for Generation X, and then cohort effects among millennials and Gen Z, they generally decreased. And interestingly, we saw that there was cohort deviations were highest among natural cause deaths. So I'm just going to touch on this slide briefly, but these graphs show the intra-cohort effects for a mid-generation X cohort. And when I say mid-generation X cohort, these are people that were born in 1974 or around there. So the lighter line indicates the predicted mortality, as determined by just the age and period effects. And the darker line is the predicted mortality determined by the age, period, and cohort interaction effects. So what we're looking at here is if there's a difference between the two lines, because that difference indicates that there is a presence of cohort effects. I'm just going to focus on the unintentional drug toxicity cohort as well, because these are the differences that we found were significant. So you can see here that cohort effects vary as the cohort ages, with positive cohort effects between 2001, 2004, which then turned a bit neutral in that middle period there, and then became positive again from between 2013 and 2020. So these are some really interesting findings that kind of counteract the idea that cohort effects or mortality cohort effects are consistent through a person's life, and we can now see that they kind of vary by period and age. So methamphetamine-related deaths are only a small proportion of Australian deaths, but they're increasing, and the shifting age mortality patterns and the move towards older age groups suggest that there's the influence of broader cohort factors. And we saw there were some variations in the cohort effect or in the age effects between the cause of death. So younger people face a higher mortality risk from unintentional injuries, while older people have a higher risk from natural causes. Mortality risk from intentional self-harm and drug toxicity tends to span a broader age range. So these trends are what we kind of expected to see because they're due to the nature of these causes more generally. So now I'm showing it just the unintentional drug toxicity age effect, and I'm comparing against the age effects that were found by Fujita, Amazu, and colleagues of all overdose deaths in the US. And just to note, the age period cohort analysis methods that we used were a little bit different to the ones they used, so may have produced some slightly different results. But generally, like overall, the age effects largely follow a similar shape. Although they have positive effects occurring a little bit later from late 20s to early 60s. So it's kind of shifted a little bit over in their models. So as I mentioned before, we had positive period effects between 2013 and 2020. And when we look at that period in terms of opioid co-involvement, firstly, we can see that opioids have always been involved in these deaths. And secondly, we can see that there was an increase in deaths both with and without opioid involvement from 2010 to 2016. But unlike in the US, there was a 9.8% increase in the proportion of methamphetamine-related deaths without opioid involvement. So this is suggesting that the period effects are in part due to that increase of deaths without opioid involvement. So the graph on the left show that from Mann and colleagues show that there's been a large increase in the volume and frequency of amphetamine-type stimulants seized at Australian borders since 2011. This is kind of suggesting that there's been more methamphetamine coming into the country due to higher demand during this period. And this is likely contributed to the period effects we see in the graphs before. And on the right side in yellow, you can see the percentage of participants from the Injecting Drug Use Reporting System, or RDRS, who reported using crystal methamphetamine. And in orange is the median number of days participants reported using it in the IDRS. So similar to the trend in seizures, since 2010, there has been an increase in the proportion frequency of IDRS participants using crystal methamphetamine. So we know that around this time, the purity of crystal methamphetamine increased and the cost decreased. So this suggests that the changing market characteristics and consumer preferences have influenced the positive period effects we see. And we now know that this has affected all causes of death, not just drug toxicity. So this is a graph from the UNODC of final destinations of methamphetamine shipments between 2019 and 2020. So the darker the shade indicates the larger amount of methamphetamine being seized, with the country as the destination for the shipments. So as you can see, Australia is one of the highest or the largest final destinations of methamphetamine shipments worldwide. So our shipments are predominantly being produced in North America and enter the country through Malaysia. But although due to the high demand and favorable profit margins, we're increasingly being targeted by the Mexican cartels. So we saw some positive cohort effects that were evident from late baby boomers to early millennials, but mainly encompass people born among Generation X. So this is saying that Generation X are mainly the ones experiencing methamphetamine-related deaths. And when we look in combination with the intra-cohort effects for Generation X, we can see the people in their 40s between 2013 and 2020 had the highest mortality risk. So on the right side of the slide there is the proportion of drugs participants in the Supermix cohort initiated injecting with. And those not familiar with Supermix back then, it was just a Melbourne-based cohort of people who inject drugs. And as you can see in the graph, there was a high prevalence of methamphetamine powder or speed injection initiation in the 1990s and early 2000s, when Generation X were in their adolescence and 20s, which then fell off after 2004. And we think that this may have increased Generation X's mortality risk as the market shifted to crystal methamphetamine in the 2010s. So another factor involved is the observed changes in injecting drug use initiation, which you can see on the right. So Price and colleagues found that among people who inject drugs, there's been an increasing age at first injection and a longer duration since initiation. So as the age of initiation increases and fewer younger individuals begin injecting, the demographic profile of people injecting drugs becomes older over time. And that kind of concentrates the risk within those older cohorts, notably Generation X. So the cohort effects also show that there was a lower methamphetamine mortality risk observed among younger generations. And when we look at some statistics from the National Drug Strategy Household Survey, this is perhaps unsurprising. So on the right-hand side of the screen in pink, you can see that the age of first trying methamphetamine is getting older, as it did increase from 20 to 23-year-old between 2001 and 2019. But in the dark red, you can see the percentage of Australians aged 14 to 19 who've used methamphetamine in the year prior, which has dropped from 6.2% in 2001 to 0.9% in 2019. And the lower methamphetamine mortality risk and also the lower methamphetamine use observed among younger generations is also part of a broader trend of decreasing risk behaviors among young people seen in Australia and internationally. And as reported by Scully and colleagues here, the prevalence of past month alcohol, cannabis, and tobacco use among Australians aged 16 and 17 has decreased considerably over the last 20 years. And it appears that methamphetamine use and methamphetamine mortality is kind of following suit here. So this could be due to a range of factors, and they're probably quite interrelated, but could be due to some improved education about the associated risks of using methamphetamine, as well as strict regulations, the impact of social media, and importantly, the stigmatization of methamphetamine, potentially making it a less desirable drug to take among younger generations. So I've come back to have a look at Fujita, Amazu, and colleagues' age period cohort results for overdose deaths. But this time we're just looking at the cohort effects. So they found that mortality risk remained stable in the pre-1947 cohorts, and then started to increase with like a J-shaped pattern among baby boomers. And then there was a reduction in mortality risk seen among Generation X, followed by an increase again among millennials. So these are pretty different results to what we see here in Australia, but they suggest that the rapid growth of fentanyl as a primary cause of opioid overdose has affected more recent both birth cohorts in higher rates and is contributing to this bimodal age distribution that they see over there. So what we're seeing here in Australia among young people is in sharp contrast to this rising youth mortality seen in the US, where younger generations are engaging in riskier drug use patterns, including increased methamphetamine and opioid co-use in a more saturated drug market. So one of the main limitations of this study was that it only covered a 20-year period. So due to the NCI limitations with the NCIS, we couldn't analyze each generation's entire lifespan, so which makes it hard to compare between generations. And while we include all methamphetamine-related deaths reported to Australian coroners, there may be some systematic biases within the NCIS, such as underreporting, classification, and also some changing practices in toxicology, which may have increased the likelihood of identifying methamphetamine in more recent deaths, which potentially may have inflated the period effects we see. Additionally, we didn't account for whether participants had a recorded history of injecting drug use or whether they use opioids at the same time in the APC model. And as these are mortality risk factors and are likely quite common in our sample, they may have affected our findings. So currently, there are no available pharmacotherapy options for people who use methamphetamine. And much of our service sector is really set up for people who use opioids. And combined with a high level of stigma associated with methamphetamine use in Australia, we see that there needs to be a greater availability of low threshold services for people who use methamphetamine that are really able to meet people where they are. Given the increasing age at death we're seeing here, we really need specific services for older people who use methamphetamine, including enhanced aged care options for people who use methamphetamine, as well as combined mental health and treatment services that can cater to the specific needs of older generations. Because we're seeing increasingly complex medical and psychosocial presentations related to methamphetamine use among this cohort. Increasing mortality rate due to natural causes, which is largely from cardiovascular disease, highlights a real need for improved access to cardiovascular screening and early management to really help reduce this mortality. And these are trends that also we've been seeing in other countries in the US and Canada who've reporting these rising levels of cardiovascular disease related to regular methamphetamine use. And in the UK, they've been trialing some community-based outreach cardiovascular disease screening. And that's been trialed with other marginalized populations. And we could think about applying some of those trials in Australia. These are my references. Just like to acknowledge the the National Coronial Information System for the use of the data, and the Victorian Department of Justice and Community Safety, as well as a big thank you to the co-authors for their guidance. And thank you all for listening.
Thank you, Oisin. That was fascinating. I really enjoyed the visualizations you used to show, the age period cohort effects. Otherwise, there's no chance I was getting my head around that. While we get you to stop sharing your screen, I'm going to invite Amanda, our panelist, to turn on her camera and microphone. Thank you. Welcome, Amanda.
Hello.
Hello. I wonder if you might like to offer any reflections on the work that Oisin has just presented. But before I throw that to you, I'll just remind everyone that the Q&A is open for you to submit your questions, and we'll get to those after Amanda has said a few words.
Yes, so thank you for inviting me today. Well, firstly, just picking up on that point, Alice, that you made, Oisin presents this data and makes it look relatively simple, but this was a really complex piece of work that he navigated brilliantly. So well done, Oisin, and his visualizations are fabulous. I guess just a couple of points that I wanted to pick up on. Firstly, the kind of co-use of methamphetamine and opioids. At the MSIC, they currently have unprecedented numbers of people who are injecting methamphetamine. It's actually surpassed the numbers of visits for heroin. I'm not sure if it's still there, but it's been quite high for some time. So we've definitely got this kind of co-use happening, and it's starting to show up in the mortality. So I'm doing a bit of work on heroin-related mortality, and if you flip the graph that Oisin showed in terms of the contribution of opioids in methamphetamine, I'm also seeing quite a larger component, if you like, in the opioid deaths, where the period effects are driven in part by, it's increasing methamphetamine involvement. I think it was almost a third of heroin-related deaths in 2020 had methamphetamine on board. So that kind of really complicates the picture. I'd also point out just how complicated these deaths are for the coroner to determine, because it's wrapped up with chronic disease. Is it an acute cardiac event? Is it a chronic disease that's just waiting to cause the acute cardiac event? And what role does methamphetamine use play? So obviously that's really complicated. And we're seeing increasing prevalence of chronic disease among this group. And I guess two final points I'd make on that, and I'm not sure if any of the clinicians are online, but we really aren't set up, irrespective of whether we yet have a pharmacotherapy for methamphetamine use. Even our withdrawal services aren't well set up. So methamphetamine withdrawal is quite different than opioid withdrawal, and it's quite unpredictable, and a week within a withdrawal unit just isn't enough. So we kind of need to have more viable options for these groups who do really have complex needs to try and reduce some of these harms. And the final point that I would make is that the stigma related to methamphetamine use in this country is just, it's such a barrier for people to seek help, and it's causing further harm. And I don't know how we resolve it, but we absolutely need to keep advocating around the stigma specifically targeted for methamphetamine use, because it does stop people coming in for, it stops people coming in for all sorts of health problems, including, underlying chronic conditions that if they're caught early, then we could absolutely prevent some of these deaths. And I'll leave it there. Thank you.
Thanks, Amanda. Okay, we've got a number of questions coming in. There's a couple here from Cliff Deo around the cardiovascular effects that you mentioned. So asking whether your research can answer how much of the increase in methamphetamine cardiovascular-related death is due to the number of people who use methamphetamine or increased cardiovascular effects of the methamphetamine use.
Yeah, it's an interesting one, because we definitely, more people that are using, there's going to be more chance of having a cardiac event related to methamphetamine. But as we saw, the cardiovascular diseases is continuing to go up, where we have all other indicators look like it's kind of going down a bit, like the toxicological, the drug toxicity is trending downward, and also I think we've got use kind of plateauing off as well. So the the work is kind of showing that there is that increased cardiovascular effects from the regular methamphetamine use. And that's likely to go up as this cohort ages. Because obviously as you age, you get there's a higher risk for cardiovascular disease. And that's gonna, yeah, be compounded as the years go on, I think.
Yeah, you mentioned in your presentation that internationally there hasn't been prior work using age period cohort analyses haven't examined by cause of death.
No.
Which I found super interesting, given what you're just saying now about natural causes and how related to age that is. Is that not a big flaw of international data?
Yeah, so most of the other stuff is just looked at overdose. And because I think that's how in the US it's a little bit easier to get the overdose data that they can work on rather than figuring out how to get, and define the cohort. Like obviously people could if they wanted to with some of the research that's previously done, but I don't think they've used those databases in the same way. But yes, that is a flaw that hasn't,
I see. So they have looked at specific causes. They haven't grouped a whole heap together, but they've just honed in on
just like overdose, yeah.
Yeah.
And sorry, I was just going to add that this is the beauty of this data source in that we can look at the other underlying causes of death.
Yeah, I agree. It's great. So further to the question about cardiovascular or cardiac effects, any suggestions, this is going to be a big question, about how to increase screening and management for methamphetamine-related cardiovascular problems?
Yeah, big question. But I think it's obviously just going to take a bit of money, but everyone that is presenting to different services for methamphetamine-related reasons, or they're being flagged for having methamphetamine or use, needs to be we need to be setting up this like bench, like a baseline of their cardiac health and kind of getting that early, and so we can kind of catch if there's anything changing from regular use. And more integrated screening into different aspects of their people's health systems, I think, is needed. But I was chatting with a clinician recently, and I was like, very just need money to do it.
So can I just add on that one, Alice? I think arguably outreach services is the way to go. And I was in Surrey Hills near some of the public housing the other night, and they actually had a medical van out there. Like they had a laundry van and they had a medical van, and the residents were coming out and they were seeing a medical practitioner, because a lot of these people aren't going into health services. So if you can find them where they live and where they hang out, that's and it seemed simple. I don't know how much that cost, but it looked like a great idea and people were using it.
Yeah, that's great. I think we see more of that in the general population now too. So it is great that that's now reaching more broadly. Okay, a question from Chris Homewood. Really interesting study. He was wondering about the confounding effects of increasing cocaine use. Should the analyses include cocaine use, looking at cumulative mortality?
Yeah, cocaine. So we initially had a little bit of a look at the cocaine, how cocaine impacted these deaths at the start. And we didn't really, there wasn't that many that involved cocaine. I think it was something about maybe 10% had cocaine I'd have to check that, but there was a small proportion that had cocaine in their system when they died. It was, or maybe a little bit less. I can't remember the exact numbers, but it was pretty, it wasn't, there was a lot more other drugs that were more commonly involved rather than cocaine. Cocaine was not that common, and but it's definitely increasing. And it'd be important to look at that from an age period cohort, standpoint soon.
Now this one might need a bit of help interpreting. So this one's from Marsha, 78% males. What is the time period, and is it all drugs or only methamphetamines, and is it polydrug use?
So this is for the period. So the first part we opened up, it was from 2001 to 2023. So we included all deaths that were, or all cases that were closed from the NCIS that involved methamphetamine. So they either had methamphetamine on board in their system, or the coroner detailed that the underlying or contributory cause was due to methamphetamine.
Yeah. Okay.
And that's so it includes all drugs, but methamphetamine was involved at some time in their death.
Mm-hmm.
Yeah.
Okay, and to dig into that a bit further, there's a question here around co-use of substances, and if there's any information about whether people are using it in the same injection or using opioids to come down from stimulants, or whether that that co-use is actually concurrent or over a longer period of time.
Yeah. So that's one of the limitations with the data source, so the National Coronial Information System. Sometimes that will be mentioned in the reports, but a lot of the time there's no way of them to know the nuance of what was actually happening in the chain of events before someone died. So normally what you would get is that it's just this is the stuff that's there. We don't really know the context. So sometimes it's hard to make the inferences from the data because we don't know a lot of the context around those deaths.
Yeah.
And in part that will be some of the, co-determining that another drug was involved will be the levels in toxicology that are taken post-mortem. But yeah, we've got absolutely no way of knowing, what the kind of time frame was on how people were using the drugs.
Yeah, that makes sense. So I had a question about the cohorts, and in particular the earlier cohorts, and then your study period starting from 2001, and what that means for those earlier cohorts, and whether perhaps you've reduced the at-risk population, well, not you, but the at-risk population is reduced by there being some earlier deaths in those cohorts before your study period begins.
Oh yeah, absolutely. Yeah, that is like the main limitation is that we only have those 20 years from the NCIS. So yeah, so there's definitely going to be some underreporting in there, and the cohort, the real cohort effects that we they're going to be higher and potentially lower in some cases. We don't really know, but yeah, there's definitely the period the cohort effects in those like especially baby boomers, when we're only catching like some of the later years of their life, or not the later years, but like the when they're 50 and 60.
Yeah.
And the same within the younger generations as well. So people that they may like Generation X, we're only really looking at right at their start of potentially with their when they're using, or like, so it's a bit hard to compare the generations, but we can just look at generations as by themselves.
Yeah. And so is that's a sort of a systematic bias, like you would know that the earlier generations, the deaths will be underestimated, and then the later generations, the deaths will be.
Well, the deaths won't, yeah, so the deaths, but the cohort effects would be different depending on if we had everybody's whole life. Yeah. The deaths that we've got are just the only ones that we were able to get for.
Of course,
yeah.
Yeah. All right, thanks, Oisin. Okay, question here about smoking and related CVS mortality risk. Is it excluded? Not sure.
No, so smoking, no matter how people use the methamphetamine, they were included in the analysis, but we didn't know a lot of the circumstances with the death. We only looked at, initially we only recorded injecting drug use, but Yeah, so we didn't actually account for the method or the modes that they consumed the methamphetamine in the analysis, in the age period cohort analysis, which would be really interesting because that may have completely different trends going on. But yeah, we couldn't include that in there, unfortunately.
Yeah.
And presumably, Mike, you're also asking about tobacco smoking as well. And that's not something that there will be a good proportion of this group who also have a history of smoking. So yes, it's a very good point.
And still on the cardiovascular topic, Nick Buckley's made a comment about most cardiovascular deaths not being reported to the coroner. So you actually, yeah, okay, nodding. Yep, we're all over this.
So, and to do that, to actually estimate the true burden, and it's a great point, Nick. You're probably better off looking at the ABS deaths registry data, because then you can actually have a look at the kind of the broader population of deaths, like the true population of deaths, rather than just those reported to the coroner, and look at cardiovascular disease. Although you would hope, it's probably not true, but you would hope that anywhere in those deaths where methamphetamine's captured, then they're also captured at the NCIS, but probably not.
Yeah. Okay, yeah. All right, we might make this our final question from Cliff Deo again, commenting that there's not a study reporting prevalence rates of meth-related cardiovascular disease in a random sample of people who use methamphetamine. How would you feel about using coroner's data for that purpose? Do you think it would be a good proxy for natural cause of death prevalence in the general population?
No.
But possibly not for those. It's an interesting idea, but possibly not for the reasons that we've just talked about. Like,
Yeah.
I think that there are a lot of deaths that seem like this is chronic disease and this is what caused the death, that probably don't even rate a mention of there being drugs involved, so they don't appear in the coroner's data. And if it's not an unexpected death, then it's not going to appear in that data set either. So I think it would probably be an underestimate. Hopefully that answers Cliff's question.
I think so, yeah. All right, we might wrap up there. So I'd just like to thank you both for a fascinating presentation, a really riveting discussion, and thanks to the audience for engaging with your great questions. Before we close, I would just like to highlight what's coming up in the next few weeks from the NDARC webinar series. So next week, we have Tim Pietowski talking about the Wave 2 findings from the World First Steroid Checking Trial. And the following week, on the 12th of June, we have Dr. Lou Mills talking about Australia's burgeoning love of medical cannabis. And of course, the NDARC Annual Research Symposium on the 26th of September. You can register using the QR code there or find more information on our website. So thanks again, everyone. That is enough from me. I hope you enjoyed today's session, and we look forward to seeing you all next week. Have a good afternoon.